Hello everyone. Thank you for joining today's Web Interface Support webinar. This series of webinars is for the Accountable Care Organization, ACOs, and groups that are reporting data for the Quality Performance category of the Quality Payment Program through the CMS Web Interface for the 2018 performance period. These webinars will highlight important information and updates about reporting quality data and provide ACOs and groups with an opportunity to ask CMS subject matter experts their questions. During today's webinar, we will also share links to various resources and other information that will appear as announcements on your screen. Please note that these calls will only focus on reporting data for the Quality Performance category. We will not cover reporting data for the other performance categories during these calls. Now, I will turn it over to Sandra Adams from the Center for Medicare at CMS. Please go ahead.
Thank you. Good afternoon, everyone, and welcome to the CMS Web Interface Quality Question and Answer session for the 2018 CMS Web Interface. Next slide, please. This is our disclaimer slide. If you have any questions about this slide, you can please call the Quality Payment Program Help Desk. Next slide, please. We do have the CMS Web Interface webinar recording, slides, and transcripts now posted for the webinar that occurred on January 30th and the webinar that occurred on February 6th. Next slide, please. So now a few important reminders. First, the CMS Web Interface reporting period will be open until March 22nd, 2019. It will close promptly at 8 p.m. Eastern Daylight Time on March 22nd. This slide will tell you information about how you can sign into the web interface, and also would like to remind you that your web interface submission is automatically accepted. There is no need to push a submit button. Next slide, please. Okay, this is a reminder about a CMS-approved reason as a way to skip a patient. Should you require a CMS-approved reason, you have to go through a process of submitting your request to the Quality Payment Program Service Center. This slide tells you specifically how to submit the request, and also to what information to include and with your request. Next slide, please. Okay, again, to submit a request for a CMS-approved reason, you would send an email to the Quality Payment Program Service Center. And again, the instructions are to submit one request per patient per measure. Use 2018 CMS-approved reason request in your subject line, and then here's the information that you should include with your request. And please do not include personally identifiable information or protected health information. Next slide, please. Here's a reminder about upcoming weekly support calls. We will have a support call every week until the last week of the CMS Web Interface reporting period. There's the address for the Web Interface Support webinar flyer, and you can contact Ketchum, the CMS quality team at ketchum.com if you have any problems with registration or audio issues. Next slide, please. And now Angela Stevenson will present some frequent measure questions.
Hi everyone, this is Angie from the PIMS Measures team. Today we're going to review a few questions that we have received for the PREV 12 measure. The intent of that measure is the description is the percentage of patients aged 12 years or older who are screened for depression on the date of the encounter using an age-appropriate standardized depression screening tool. And then if positive for depression, a follow-up plan must be documented on the date of the positive screen. Question 1 is, if a PHQ-9 test was done on the patient and the score is 5 or greater, but the doctor documents the result as negative, even though this is considered clinical depression, can we take this as a negative result? The answer is yes. Ultimately, whether or not the patient is considered positive or negative for depression would be determined by the eligible clinician reviewing the age-appropriate standardized tool results and based on their knowledge of the beneficiary and guidance for the tool being used. The name of the tool used and the result must be included in the documentation in the medical record. The measure does not require documentation of the specific score. The results from the screening tool must be reviewed and documented as positive or negative for depression by the eligible clinician on the date of the encounter to meet the screening portion of the measure. And if the result is positive, documentation of a recommended follow-up is required at that visit. Next slide, please. Okay, question 2. A patient has a medical record documentation of a diagnosis of major depression March 14th of 2018. And on September 18th, the patient had a PHQ-9 score of 0 and the medical record documentation that they were negative for depression. Would we include this screening in the numerator, or would this patient count as an exclusion? Using this example, the patient would be excluded from the denominator if there was an active diagnosis of major depression or bipolar prior to the encounter with the most recent depression screening. If the diagnosis occurs during, but not prior to, the encounter with the most recent depression screening in the measurement period, then the patient would not be excluded. Question 3. We had a question that asked if they had all patients routinely complete a PHQ-2 and a PHQ-9 at the same visit, would the PHQ-9 satisfy the numerator for patients with a positive PHQ-2? Would it satisfy the numerator as for a follow-up? The answer is no. The initial screening results must be reviewed and documented as positive by the eligible clinician, as well as documentation that the follow-up plan recommended is to do additional evaluation for depression. If additional screening, such as PHQ-9, is completed during the same encounter as an initial positive screen of a PH2, as an example, the quality action for the numerator is met. Documentation of the results of the additional screening is not required for this measure. In other words, the follow-ups. If the recommended follow-up is additional screening, we don't need a score for that screening. Thanks very much. I'll turn it back over to Sandra Adams.
Thank you, Angie. So now we'll walk through some resources and where you can go for help. Next slide, please. Here are some documents that are available on the Quality Payment Resource Library. Next slide, please. Also available on the Quality Payment Resource Library is a link to some CMS Web Interface instructional videos listed here. Next slide, please. And then here are some websites. The website for the Quality Payment Program Help and Support, and also the Quality Payment Program webinar library links are here as well. Next slide, please. And then here is the website for the Medicare Shared Savings Program, and also the Quality Measures Reporting and Performance Standards for the Medicare Shared Savings Program and the ACO portal. And also the website for the Next Generation ACO model and the Next Generation ACO Connect site. Next slide, please. And now we're going to open up the Q&A session, and here are instructions should you have a question that you would like to ask. Thank you.
Great, thank you, Sandra. So you can ask questions via chat or via phone during this portion of the webinar. To ask a question via phone, please dial 1-866-452-7887. And if prompted, please provide the conference ID number, which is 596-7388, and be sure to press *1 to be added to the question queue. Also, if you do have any follow-up questions or clarification that you want to share with us during the webinar in the chat, please do type follow-up question at the beginning of your chat question. That way you can flag that for us. So our first question here asks, can you please confirm if the deadline date for the web interface for the 2018 quality reporting period has changed to April 2nd?
Hi, this is Lisa Marie. I just want to note and emphasize that the web interface closes on March 22nd at 8 p.m. Eastern Daylight Time. Again, it's Friday, March 22nd. And again, this is to submit data or report on your Benny sample for the web interface. For all other performance categories, such as improvement activities and promoting interoperability, the deadline is April 2nd. But again, for the CMS Web Interface and to report all your data on your beneficiary sample, the deadline is March 22nd at 8 p.m. Eastern Daylight Time. Thank you.
Thank you, Lisa Marie. Our next question is for Prev 13 statin therapy. For the denominator confirmation risk category 2, familial and pure hypercholesterolemia are the diagnoses listed that meet this population. Does the diagnosis of hyperlipidemia or mixed hyperlipidemia put a patient in the denominator population 2 risk category as well?
Hi, this is Angie from PIMS. No, only patients who were previously diagnosed with or currently have an active diagnosis of familial or pure hypercholesterolemia are included in the denominator for population 2. A diagnosis of just hyperlipidemia would not be included in the denominator. Thank you.
Thank you. Our next question is on Prev 9 BMI. Does the provider have to document abnormal BMI in the note to use a follow-up of exercise diet from an HTN diagnosis, or can they use a follow-up from a different diagnosis, HTN for example, as long as the abnormal BMI is documented in the chart?
So this is Deb from the PIMS team. You do have to have the follow-up plan and the abnormal BMI documented on the same encounter. The recommended follow-up does not necessarily need to include terminology like for abnormal BMI if that recommended follow-up is pertinent to both the abnormal BMI and, say, a secondary condition like hypertension. But you do have to have the BMI, the abnormal BMI documented along with the recommended follow-up plan on the same encounter. Thank you.
Thank Thank you. This next question says, for IBD, last it was mentioned that we would not exclude a patient if they received a heparin flush in the hospital, for example, because it was not ordered. And they're asking to please clarify because any medication given in the hospital is ordered, and they say that they have always excluded a patient if they had any type of heparin during the measurement period, including a flush.
Hi, this is Olga from the PIMS team. So if the heparin was prescribed for the patient, then it would meet the denominator exclusion. If there is any brief use, so this would be to heparinize an IV line. In other words, it's added to the IV catheter to keep it open, then that would not meet the definition for a denominator exclusion.
All right, thank you. And Stephanie, do we have any questions on the phone at this time?
We do. Our first question is from Jason Shropshire.
Hi, can you hear me?
Yes.
Hi, I need some clarification regarding a question that was asked last week. So the response that was given is in direct contradiction to something I received from QPP. So my question is in regards to Prev-10 cessation counseling. So someone asked if you had instructions on your EHR regarding things the patient could do. It was never really clarified whether or not yes or no that will count, because they referenced something in the specifications that say you can't use a brochure or pamphlet, but something that is given to the patient on their EHR personal instructions is not a brochure or pamphlet. And when I asked that question to QPP, they said, yes, you can use it.
So Jason, this is Deb from the PIMS team. Do you have a case number that we can go back and reference so that we can both, take the information that's from the specification in regards to pamphlets and the response that you were provided and look into that further?
I don't have that in front of me right now. I'd have to find it. Who could I send that to?
If you happen to find it before the end of the call and include it in the Q&A, we can look it up that way. If not, it may be easiest that somebody else may be able to tell me that this is not correct, but I would say even open up a new QualityNet question with that case number referenced and ask them to go ahead and send it to the PIMS team to address.
Okay, I should be able to find it before the end. I will just type it into Q&A.
Okay, I'll look for it.
And
Thanks.
if you don't, and if you're not able to find it before the close of the webinar, you can send it to me. This is Lisa Marie. My email is lisamarie.gomez1@cms.hhs.gov. You can send that to me, and I'll make sure that our web interface team gets it and we can address your question.
Okay, thank you.
All right, our next question, this person says, we have a few patients we have come across in the HTN measure that we would like to ask what to do in the following circumstances. So they say a couple patients have refused both their blood pressure being taken and being prescribed blood pressure medication to take. And they said a patient had white count syndrome, 2 patients had an urgent care and or emergency room visit at the end of December for acute issues. Their blood pressure was high during that visit but was normal at their last office visit in the office with us. Will we use the last blood pressure taken in the office at our practice instead of the ER urgent care blood pressure?
So this is Deb from the PIMS team. If a blood pressure reading was not taken during the performance period, this would be considered a numerator fail. There should be a blood pressure sometime within the performance period. The measure does not include a patient exclusion for refusal. To get into some of the other parts of your question, like if there was an ED or urgent care, you do not have to use that blood pressure value and can use the next most recent BP value, as blood pressures from emergency departments are not intended to be part of that measure. If you have additional scenarios and the posted measure specification doesn't address them, You can certainly either ask some follow-up questions within the Q&A box or go ahead and open up a QualityNet Help Desk ticket, and we should be able to review those additional scenarios. Thank you.
Thank you. This next question is on PrEP8 pneumonia. Does it matter when the patient received the vaccine prior to 2015 to meet the intent of the measure, or as long as the patient received the vaccine, regardless if the type is known, is that acceptable?
Hi, this is Olga from the PIMS team. So you need medical record documentation that states the year and the type of pneumococcal vaccine provided. If the beneficiary reported prior to 2015, you need documentation indicating receipt of a pneumococcal vaccine, and that would be sufficient. If it's reported after or during 2015, then you need documentation indicating the year of the vaccination and confirmation of the type is required.
Great, thank you. Our next question says, can you please confirm that MH1, PrEP13, and CARE1 are all pay for reporting in performance year 2018 for all ACOs? And they're also asking to confirm that these three measures will not be scored for ACO-eligible clinicians.
This is Kristen from RTI, and as far as the first question, yes, so all those measures are pay for reporting for all ACOs in PY 2018. For the second question, I'm going to have to ask someone from MIPS to answer that.
Hi, can you repeat the question?
Yeah, it's to please confirm that the three measures, so MH1, PrEP13, and CARE1, will not be scored for ACO-eligible clinicians.
Hold on just 1 second. On the line?
Olivia, are you on the line?
And we can jump back to this one later if needed.
Yeah, let's jump back.
All right, so this next question, the person says they need some clarification to the denominator for the MH1 measure. They say within those specs it states to find the earliest PHQ-9 date during the index period, but then indicates that we are to find the first instance of a PHQ-9 with a score of greater than 9. Are we to use the first instance of any PHQ-9 during the index period, regardless of the score, or should we use the first instance of a PHQ-9 with a score that is greater than 9 during the index period?
And this is Deb from the PIMS team. The intent of the MH1 denominator criteria is for you to be able to confirm both the diagnosis of major depression or dysthymia as well as the PHQ-9 greater than 9 result. The PHQ-9 greater than 9 result that you're looking for and would use as an index date would be the first instance of a PHQ-9 greater than 9. If you need any additional clarification, please let us know. Thank you.
Thank you. And Stephanie, we can take a question on the phone at this time.
Our next question is from Yun Tu.
Hi. I would like to ask a question about the IBD measure. If there are antiplatelets that are not listed in the COATS document, supporting documents, can we count them as exclusions or exceptions?
So this is Deb from the PIMS team. I would recommend looking at the measure specification to find out which of the medications are allowed for that measure. I can certainly pull it up just to verify. I believe in the past those medications were considered to be all-inclusive, but I can double check that. Although if they are all-inclusive, I would anticipate that that is going to be documented within that measure specification.
Yes, okay if you don't mind to look up, for example, Brilinta is one of the antiplatelets that's not listed in the coding codes document. But
sure. So the thing about those medications would be both the name brand and the generic medications are acceptable. So that I know that particular medication is acceptable for that measure because the generic med is listed.
Okay, perfect. Thank you.
You're welcome.
Thank you. All right, our next question asks, will the PY 2018 benchmarks for PREV-10 be updated to reflect the change in populations used for performance calculations?
This is Olivia. I can take that one. The web interface benchmark for PREV-10 for 2018 actually has already been updated to reflect population 2.
Great. Thank you, Olivia. And I think we're actually going to jump back to that question from earlier now. So the question again is to please confirm that the 3 measures, MH1, PREV-13, and CARE-1, will not be scored for ACO-eligible clinicians.
This is Lisa Marie. I'm going to speak with regard to groups, and then Sandra's going to speak with regard to ACOs. But in general, like if there is a measure that does not have a benchmark, you still have to complete reporting and meet reporting requirements, and you will not be scored, or that will not be included in the denominator. So, but it's important that you do complete reporting, because if you do not complete reporting for those measures without a benchmark, then that measure will be included in your score, which will actually lower the score if you don't complete reporting. Sandra?
Yes, and this is Sandra from the Shared Savings Program team. And all measures that, whether they're paid for reporting or not, are scored, and ACOs receive reports, and so you're scored as an ACO, and the score will be in your report. If a measure is paid for reporting, then the ACO will get all of the points for that measure, but they will still see a score on their ACO report.
Thank you. And next, I do see a follow-up question on CARE2 HTN. They're asking to please confirm that urgent care visits are included in the accepted visit types in the coding documents. However, ED is not.
So this is Deb, and I haven't had a chance to pull up the coding document, but I would say if the coding for urgent care is included in that document, then it's acceptable to use. What we typically tell people about the hypertension measure is any encounters that are not considered eligible, you do not have to use because the measure developers purposely left them out. However, we don't ask ACOs and groups to confirm the type of encounter. If you find that the most recent blood pressure reading is in control and you want to use that, we do not ask that you can confirm which type of encounter that came from. And the rationale behind that is for instances like the emergency department, the reason those were left out is it can be assumed that oftentimes if you go to the emergency department, your blood pressure will be out of control. However, if it's in control, it is a sign that the blood pressure is being controlled. So I would say take a look at the coding document, and if the urgent care coding that you use is part of that coding document, then it is considered eligible. If it is not, and you do not want to use that encounter to identify a blood pressure reading as the most recent, you are welcome to not include that BP reading.
Thank you. Our next question is on the HTN metric. They're asking, is a description of hypertension documented in the medical record enough to include the patient in the initial population, or is the requirement that hypertension be coded?
So this is Deb. You do not have to verify coding within the web interface measures. So certainly documentation of essential hypertension is acceptable for confirming the patient has hypertension. The only thing you want to make sure of is that you are not pulling patients into your hypertension measure that then you will be required to submit a numerator compliance on that really aren't intended to be part of that population. But documentation of hypertension in the medical records is appropriate.
Great, thank you. And this next question asks, if the record doesn't specify retinal exam, would vessel and macula findings be enough to support a retinal exam was completed? And if not, what documentation is needed to support this?
So this is Deb again from the PIMS team. Oh, go ahead, Angie.
I was just going to say that the documentation does need to support that it was a retinal exam. So I don't think that would meet the measure, but Deb, I'd like your clarification. Thank you.
Sure. I think the one thing we were able to pull up is we had a physician take a look at a very similar question that came through the QualityNet help desk. And what we have been told is that it is reasonable to assume that they did the entire exam, as some eye professionals use maculopathy, sorry about the not being able to say that very well, term instead of retinopathy. So they can often be viewed interchangeably for the measure. What I would recommend is to ensure, and maybe this means confirming with the provider, that is what that documentation means. But we are finding that some eye care professionals do use some different terminology for that exam. But you definitely want to make sure that what is happening is a dilated retinal exam.
Great, thank you. And Stephanie, we can take a question from the phone at this time. Stephanie, do we have any questions on the phone?
I'm sorry, we do have one from Nicole Geyer.
Hi, thank you for taking my call. I have a question on the CMS pre-populated flu data. It seems like I collect for multiple ACOs across the country, and it seems like across the board there was less CMS pre-populated flu data. And I was wondering why this was.
Hi, this is Sarah Grallert from ACO PAC. And when we were generating the samples, we too noticed that there was a drop in the number of pre-populated flu shots that we saw for PREV7. And we did a lot of research into this, and really what we were able to determine is that there was actually an overall drop in general in the population of folks getting flu shots. It's actually on the CDC website. So between the 2017 and 2018 flu season, there was I believe it was a rather significant drop.
Okay, thank you.
Sure.
Great. So our next question is on PREV13. And they say, does the allergy or intolerance of statins need to be documented during 2018, or can it be documented prior to this?
Hi, this is Angie. Go ahead, Deb.
No, you're fine. I wasn't sure if I had tagged that question or not. So
I wasn't either. Okay, thank you. Now I'm trying to think of the question again. I'm looking for it here. I had it ready. The allergy, well, there needs to be documentation during the measurement year that the reason a statin was not prescribed is due to a statin allergy. Thank you.
Great, thank you. For the next question, they're asking for IVD, is aspirin with caffeine, does that meet the intent of the measure?
Hi, this is Olga. Yes, as long as there is documentation in the medical record that the patient is taking aspirin or a combination, that would meet the intent of the measure.
Thank you. This next question says, per the medical record, the patient is in a long-term care facility. However, we're unable to find documentation that includes a POS code. How should we proceed?
Hi, this is Jessica Schumacher from the Measures team. And I can speak to this in regards of the measure MH1 because I know that measure has a clause that allows those patients who are permanent nursing home residents to be excluded. And based on the measure specification for MH1, there just needs to be medical record documentation that they are a permanent nursing home resident. There doesn't need to be a code as long as there is the documentation. And that definition for a permanent nursing home resident is available in the measure spec. I don't know if there's any others who want to jump in who have additional comments about this. Thank you. Or I guess if the caller has questions outside of MH1, if they could please submit that in the Q&A box, and we'll keep an eye out for it. Thank you.
Great. So our next question, they're asking if dipridamole alone and Brilinta are acceptable antiplatelet and numerator compliant for the IVD measure, even if they are not listed in the codes document.
Hi, this is Olga again from the PIMS team. Yes, the brand name medications as well as the generic forms are acceptable. The IVD coding document codes are considered all-inclusive for the purpose of EHR mapping, but you can also use medical record documentation to meet the numerator.
Great, thank you, Olga. And Stephanie, we can take a phone question at this time.
Our next question is from Sandy Santangelo.
Hi, thank you for taking my question. The question is around IVD2, and I just want some clarification over the denominator exclusion where it says patient who had documented use of an anticoagulant medication overlapping the measurement year. Some questions have arisen around what does overlapping the measurement year mean? Is it the measurement year of 2018 or are other dates included?
So this is Deb. That would mean that it had to have overlapped. It had to have occurred sometime during the 2018 year for the measures that you're reporting for the 2018 data. So anything that would have occurred in 2018.
Okay, thanks so much.
You're welcome.
Great. So our next question asks, while PREV 12 does not require a score to determine depression, however, if you also track MH1 depression screening, the score is required, as the lower score is how the measure is determining depression remission. Can it be explained how these two measures being used together, don't both require that score?
Sure. This is Deb. A couple of things to keep in mind. Both PREV 12, the depression screening measure, and MH1 are stewarded by different measure developers, and the intent of the measures is different. So the PREV 12 measure is intended for everyone to be screened for depression so that, of course, they can start to look at potential follow-up care. MH1, which is stewarded by Minnesota Community Measurement, is already identifying patients who have a diagnosis of major depression or dysthymia, and the intent of the measure is to achieve remission. So the measures are quite different, stewarded by different individuals with different purposes. If that didn't sufficiently answer your question, this is another case where you're certainly welcome to open up a follow-up QualityNet help desk ticket, and I guess I should say ServiceNow help desk ticket, or ask some clarifying information within the Q&A on this call. Thank you.
Great, thank you. Our next question is on Care 1. What is the best way to respond when no record of discharge is found in the patient chart? Should we put no or NA?
So this is Deb from the 10th. Go ahead.
No, sorry, Deb. I just believe this is a question regarding the template and which option to select on the template. I don't know if there's someone from that team who can speak to it.
Hi, this is Azam. In the template, you will need to select no. Please note that NA is to remove your previously selected answer from that field. So if you put NA, it will blank out the answer for that question. So to answer the question, you will need to select no. Thank you.
Thank you. Our next question says, for Prev 12, our organization has a protocol in place that states a PHQ-2 score of 3 or greater is considered positive and a score of 0 to 2 is negative. Do the words negative or positive need to be documented if we have this policy in place?
This is Jessica from the Measures team, and I can speak to this from the measure spec perspective, and when I'm done, I'll call on our friends over at the auditing team in case they want to jump in. But the measure spec clearly states that there must be medical record documentation of the provider's interpretation, and that is just to be sure that that coordination of care and that communication is clearly made available to all that look at the record. With that said, though, the measure owner has confirmed that they understand that there might be instances where it is obvious what the screening has indicated. So, for example, with PHQ-9, if the score is a 0, only then can it be assumed to be negative. And the other instance in which documentation of the tool can kind of be overlooked is if there's a date in which the screening was provided and there's automatically a follow-up written, then it's assumed that the screening was positive for depression, and therefore the provider is documenting the follow-up plan to address the positive screen. So I know that this organization seems to have a policy in place. However, there might be instances where that the screening might have a high score, but that could be the patient's baseline, so maybe the provider doesn't want that policy to apply. So if there's any type of medical record documentation for the provider's interpretation, that really is what needs to be included in the medical record and then communicated with the support team. And again, that's just based on how the spec reads. So I don't know if there's anyone from the auditing team, if there's any guidance you want to provide for an audit. Thank you.
I don't believe there's anything additional that we want to add. Thanks.
Great, thank you all. So our next question is on HTN. Would blood pressure checks during a nurse-only visit in the primary care provider office count as compliant for that metric?
This is Deb. Yes, those would, as long as that blood pressure value is considered your most recent BP. You're certainly welcome to use it.
Great, thank you, Deb. And Stephanie, we can take a phone question at this time.
Our next question is from Joanna Loescher.
Good afternoon. I have a question about verifying diagnoses. Someone mentioned earlier that that double checking of the codes to confirm the diagnoses for the of depression and ischemic vascular disease and coronary disease and all those kind of things is not necessary. Did I hear that correctly? So as we're going through, we do not have to double check the codes?
This is Deb. I'll answer from one perspective, and there may be others that want to fill in some information. We don't ask that you verify the codes, but I would certainly say that there would be times you would probably want to. Thinking about MH1 in particular, there are times when maybe what's written down is just depression. But you find that there's also a major depression code that is there. And in that case, you can confirm that the patient has major depression because you have the documentation of depression along with an appropriate code. The big thing about the diagnosis is once you've confirmed them, you're kind of putting yourself in that place where you need to ensure that you're answering the numerator, whether or not you're numerator compliant or not. And so what you don't want to do is confirm a diagnosis that maybe the quality action isn't pertinent to. But we don't ask that you confirm the actual code, that what we ask you to confirm is the medical record documentation. Does that help?
Yes. So if I'm correct, if we are confirming every diagnosis by using the codes when we're auditing and reviewing these records, that won't necessarily, that's not bad technique, correct?
No, it's not a bad technique. No, it's not a bad technique. The only thing you want to remember is that if, in cases, and Mary may want to jump in here as well, but in cases where you might get audited, having just the code is not sufficient. You also want to ensure that you have that medical record documentation to support the code.
Okay. All right, that's correct. Good. Thank you very much.
You're welcome.
Thank you. Our next question asks, can we accept a PHQ-2 or PHQ-9 with only the score and not the provider's interpretation, such as positive or negative?
Sure. So to follow up on the previous question, so technically, no, the provider must document whether or not the screening was positive or negative for depression based on all the information the provider is able to take into account during that encounter. They may have some additional information they want to evaluate. So for example, if they think the patient might be lying when they're filling out the questionnaire and so forth, there just might be other things they take into account. So the provider must document whether or not the screening was positive or negative. And therefore, if it's positive, they must have that recommended follow-up. And again, just to echo my previous response, there are only those two instances where documentation of positive or negative is not required. The first instance is if the PHQ result is a 0, therefore that can be assumed to be negative. And the other instance is if there's clear documentation of a follow-up plan to address issues with, or to address symptoms of depression, then that would indicate the screening was positive. Thank you.
Thank you. Our next question is on the CMS reason to skip for IVD. So the patient cannot take any type of antiplatelet due to an aspirin allergy with recurrent rectal bleeding and anemia.
Hi, this is Olga from the PIMS team. I would just reiterate that in order to request a CMS-approved reason, if you can go ahead and submit a QPP service inquiry and include the patient rank measure and the reason for the request. And just a reminder, please do not include any personally identifiable information in that request. Then you will be provided with a CMS decision within the resolution of the inquiry.
Thank you. Our next question is on Care 2. If a patient had a fall during the measurement year and was seen with an appropriate clinician for that fall, does this count for the measure?
This is Jessica from the Measures team. So if there is documentation of a fall, that indicates the patient is at risk for future falls. And that is included in the definition of fall screening in the measure specification. So if that is all provided in the medical record documentation, then yes, that would meet the intent of the measure.
Thank you. Our next question is, what is the maximum number to skip for each metric to not fail an audit?
Hi, this is Sandra. We don't have a number that you can skip. You should report as your data allows. And as far as the audit for shared savings programs, we evaluate and select ACOs for audit after we're able to look at the web interface submission data. So there's not, if you're asking if you can skip a certain number of patients and not be selected for an audit, there's no guideline around that.
Great, thank you. And Stephanie, we can take a phone question at this time.
We have a question from Beth Sianis.
Hi, my question was actually just answered. Thank you.
All right, Stephanie, is anyone else on the line with phone questions? We can go to the next one.
We have another question from Leslie Allaby.
Thank you. I'm calling to follow up on a question that was asked last week during this call, and I have the transcript in front of me. Thank you for making that available. So I'm going to read this. Hopefully it's not too lengthy. The question was read, and it is as follows. When using no record found in a specific TIN within our ACO, are we allowed to go outside of the ACO participants to find that data? I'm still quoting. And then they're saying that the large gastro group in their area is not part of their ACO, but they can potentially look up colonoscopy results. Is that allowed, or can they only search other TINs that are participating in their ACO? The response was, I quote, ACOs are encouraged to collaborate with physicians inside and outside the ACO, unquote. So that is all that was in the response to that question, which at least in part is asking, can we, during reporting, go to another organization to seek colonoscopy results? I would like some clarification on whether that is acceptable.
This is Olivia Berzin from RTI, and others feel free to jump in. But yes, in general, yeah, you are absolutely allowed and encouraged to look for data both inside and outside the ACO, as was mentioned on the webinar, and is also documented in the Q&A document, if that is helpful.
During the let's say today, I don't have a colonoscopy in the EHRs that I have access to, but I can go to an imaging center and say, oh, can I have this patient's colonoscopy? Okay, thank you very much.
Okay,
yeah,
hold on.
Go ahead.
Yeah, Olivia, this is Deb. I just want to clarify that we, in the past anyway, and the information that the PIMS team has been giving out, is to look for information in 2019 for things that were supposed to have occurred in 2018. You should not be looking for that information at this time. That's information that should have been available at the point of care in 2018, because the intent is that those providers would know whether or not that colonoscopy was considered up to date during 2018, and not to try and backfill information in 2019 for 2018 reporting.
Okay, that is what I recall from previous years as well. So the response surprised me. Okay, so if I can reiterate then, the allowable practice is only if you can access it during the measurement year, can you count it?
Right, and there are times that what we have found is that, maybe some of these tests were done quite late in the year. So it's not, people aren't trying to backfill information and to fill in the gaps. It's just part of the process. You're getting the mammogram results or the colonoscopy results early in the new year. But to use that information to try and backfill is where, at least in the past, and Olivia, if I'm incorrect and that has changed, please let me know. But backfilling in the past has not been appropriate.
I guess I will need to defer to CMS on that.
Okay, so that is the final answer in that case. I just, for my sake and anyone else on the line, I think it's helpful to know that. So. Okay, thank you.
So our next question asks, could you clarify an earlier comment regarding BMI counseling? Does counseling need to occur during or after the latest BMI, or can counseling occur during the measurement period?
So this is Deb. The PREV-9 measure is not tracking whether or not the actual counseling occurred. What the measure is tracking is whether or not there is a recommended follow-up plan. And the recommended follow-up plan needs to occur on the date of the encounter of the abnormal BMI. I have seen some follow-up questions in the Q&A where they're kind of questioning that that's in conflict with the look-back period. The thing to remember is if I find at my most recent encounter I have an abnormal BMI, there's not a recommended follow-up, but I look back within the appropriate look-back period per the specification, and I can find documentation of another abnormal BMI with a recommended follow-up plan, I can use that. But what that measure is trying to do is to ensure that there is a link between an abnormal BMI and a recommended follow-up plan. So hopefully that answers both the question that was just asked and some follow-on questions that have been coming into the Q&A.
Great, thank you. And that is all the time that we have for the Q&A today. And before we close out, we do just want to remind everyone that it's not necessary to request a CMS-approved reason if there is an exclusion or exception available in a measure that addresses a specific scenario. So please do review the measure specs carefully before you submit a CMS-approved reason request. So that is all the time we have for today. Thank you everyone for joining, and if we weren't able to answer your question, please do feel free to email any of these addresses on the screen for help with the Quality Payment Program, the Medicare Shared Savings Program, and Next Generation. And we also encourage you to join us next week for our next webinar on February 20th. Thank you.
Thank you. This concludes today's conference. You may now disconnect. Speakers hold the line.